Hello and good evening, everybody. This is Dr. Roshali from the medical team of USV, and I welcome you all to this ADA Live Update 2024, which is being relayed from Orlando, Florida, United States, where cutting-edge research, expert insights, and innovative solutions are converging to tackle diabetes and improve the lives of the patients. So, without wasting any much of the time, let me have this opportunity to welcome our experts for today, Dr. Amit Gupta, sir, Dr. Bansi Sabu, sir, Dr. P.M. Makkar, sir, and Dr. R.K. Sai, sir. Dr. Amit Gupta sir is our moderator for today's session. He is the director for the Center for Diabetes Care from Greater Noida. He has been the vice chair for the American Diabetes Association and advisor for the Public Health and Epidemiological Interest Group ADA 2022 and 2024, Executive Council member, National RSSDI. He's also the executive editor of Sadiko's International Textbook of Diabetes and an associate editor for clinical diabetology. Having numerous publications to his credit, it's great to have you here with us today. I welcome you on behalf of Team USV, and over to you for the further proceedings.
Thank you, Dr. Oshili, and it is really a pleasure to be here and bringing updates from the ADA 2024, the 84th scientific session happening at Orlando. A warm welcome and good evening to everyone who has joined us from India. And we are live from Orlando from the site of the ADA, and we are going to bring you the cutting edge updates which we have imbibed over a period of last 2 to 3 days during the ADA conference. So with the utmost pleasure, it is my pleasure to invite our first speaker, Dr. Bansi Sabu. May I request, yes, Dr. Bansi Sabu's slide is there. So Dr. Bansi Sabu, you all know, he is chair-elect of IDF Southeast Asia. He is currently also the member of the Membership Advisory Group of American Diabetes Association. He happens to be the past president of RSSDI and currently the vice president of DASG. He has many honors and awards to his credit, and he is a renowned figure in the field of diabetology globally. And recently, he has also been appointed as a global council member for the ESD. So this is another feather to in his cap. So congratulations, Dr. Bansi Sabu, and I would like to invite you for this important session. That what are the updates from the ADA 2024? What you have learned and what exactly you would like to pass on to our audience in India.
Thanks, Dr. Amit. It's really great pleasure that I'm here at ADA, and from here we are live. And thank you for kind words. Amit is very, very close friend and younger brother to me, so it's really pleasure to have him as a chair and moderator for this session. We have in our session also our past president of RSSDI, Dr. Makkar, and current president of our RSSDI, Dr. Rakesh Sai. Let me share my screen that what we have done in last 2 days and what live we can show you here from ADA directly. So what's new in 2024? And one very interesting thing which had come in 2024 is how you should treat your patient in 2024 who is newly diagnosed, and what should be the focus of management in 2024. And this was really very interesting session. Most of us, we all were there. And the point was, the message was very clear that treat obesity first. It is, as it's type 2 diabetes, so to treat obesity first, that's what very, very important, as nearly 90% of our adults with diabetes have overweight or obesity. So the first thing which we should do is treating the obesity. They have in their ADA guidelines also that obesity and weight management for prevention and treatment of type 2 diabetes, that should be the priority when you have. They have very clear-cut evidence that a diabetes patient, overweight and obesity weight management should represent a primary goal when you are treating diabetes. And that's the reason this year American Diabetic Association have come out with the idea that they will have also a obesity association along with American Diabetic Association. If you become a part of American Diabetic Association, you are also part of Obesity Association, which is under the American Diabetic Association. We know there are a lot of anti-obesity agents. Even metformin is also considered to be one of the anti-obesity agents. Others are the older drugs which we don't want to use. But GLP has really changed the way we were treating diabetes and obesity. And the dulaglutide and liraglutide, which are available in our country. We have semaglutide in an oral form, which is not as a anti-obesity agent, but semaglutide in a higher dose, which is available here in the Wegovy, which is available in some parts of the world as an anti-obesity agent. We all are looking for the newer molecules like tirzepatide, which is a dual combination of GLP and GIP, which is really giving a lot of good results in persons with obesity with a significant weight reduction. The pharmacotherapy primarily concerned with the GLP-1 or a dual anti-agonist, but there are few molecules which can increase also the weight in the patients with diabetes. And that's the reason. When you are choosing the glucose-lowering medication for people with type 2 diabetes or with overweight and obesity, always prioritize the medication which have beneficial effect on weight. And this is with the evidence B. The weight effect, as I told you, the some of the molecules like sulfonylurea, insulin, glinides, and glitazones, they actually increase the weight, while the molecules like SGLT2, GLP-1, and biguanides, which is metformin, which help in patients for weight reduction, and some of the molecules which we use very often in our country, like DPP-4 and alpha-glucosidase inhibitor, they are weight neutral for our patients. The magnitude of weight reduction is also very important, that how much weight you reduce. The 5% weight reduction itself will improve the significantly the glycemic control, but other risk factor also. But a sustained loss of more than 10% of the weight loss will really change the way we are treating the diabetes, which is like disease modifying effects, and possible there will be remission. If someone can have a weight reduction of between more than 10 or 15%, and it will improve the long-term cardiovascular outcome as well as the mortality too. Now, the treating diabetes, when 5% weight reduction, the major benefit is on the hypertension and hyperglycemia. With 5 to 10% of the weight reduction, there will be benefits for prevention of type 2 diabetes, dyslipidemia, PCOS, NAFL, GRD. For the 10 to 15% weight reduction, the benefits will further increase even for the obstructive sleep apnea, for urinary stress continence, CV risk reduction, and even for knee osteoarthritis. And with more than 15% of weight reduction, you will get the benefits for type 2 diabetes remission, as well as people with heart failure with preserved ejection fraction. That will also help, and that will also reverse. The combination therapy, as we treat in diabetes, we start with first therapy, and then we keep on adding and wait for the effect of first therapy, and then you add the second one and then third. And there is one other way that you can start with the early combination of therapy, because you just want a tight glycemic control early in the course of diabetes. Similarly, the combination therapy is also needed for the treatment of obesity. I mean, the adding a molecule which is not only going to reduce the significant weight, but also will have the maintenance for the persons who have obese or overweight. The anti-obesity medication which are in the pipeline, and that's really these are the molecules which we will have maybe in near future, maybe in a decade time, maybe in 5 to 10 years. And this will be very exciting time for the people with obese or diabetes, that we will not only have a reversal or a prevention of diabetes, but we will have a lot of molecules which will be available to us, which will, a physician will able to reduce the person's weight by more than 20 or 25% of their weight. Or we have a lot of people with diabetes, newly diagnosed, even we can think of their reversal of diabetes. And some of the molecules, even their clinical trials, which we are doing even in India also. As I told you, between more than 15% weight reduction to 20% of the weight reduction, many of our patients will be able to have even the reversal of diabetes. But those who will have more than 25% of the weight reduction, probably a bariatric surgery may not be required for many of our patients. The beyond weight reduction, treating obesity will improve overall health outcomes. The quality of life will also significantly improve. So the chronic disease management, when we are talking of, as we know that diabetes, you have to treat with a lifestyle intervention and medication effect. But as soon as you stop the medication, probably they will come back. So the same thing will going to happen with the obesity too, because many times our patient keep on asking, sir, how long I have to continue the medication for obesity? Even if I have decreased my weight significantly, should I continue? And then we have to explain that it's like any chronic disease management, that as you stop the medication, probably they may regain the weight as they were there. Now, in diabetes care, we know that ABC approach is A1C, blood pressure, and cholesterol. Then it came with the D and E, which are the drugs for cardiovascular risk reduction, or the drugs which we use for the patients for even weight reduction also. E's are exercise, but the S which had become very, very important. And this S is screening for complication, smoking cessation, and the self-management. These are three which is very, very important. We have to think now diabetes, not only for managing diabetes with the obesity management and all these things, but also we have to think for stopping the diabetes or preventing diabetes, and that we can think of by preventing the obesity or weight increase or treating the obesity in a persons with obese person. So when treating a new onset of type 2 diabetes, treat obesity first. That's the most important part of managing diabetes in 2024. Now, preventing the future complication, why we should think of preventing complication in the focus, because that's the primary goal of treatment of diabetes. Why you are treating diabetes? Not just for the hyperglycemia. You are treating the diabetes for not to have the complication. That's our approach of last 5 to 7 years. We understood that it's not just the sugar control is important. It is the not the glucocentric approach is important. It is preventing complication. That should be our major approach, because complication will increase the risk of death, the mortality, whether it's a renal complication, whether it's a cardiac complication, whether it's an infective complication, whether it's a cardiovascular, or even some of the patients who are very obese, a COPD or a cirrhotic or a neoplastic, all of them are going to increase the risk of death for these patients. In a newly diagnosed patient, the time to incidence of diabetes complication can be as short as 3 to 5 years. So this is very important from India point of view. This paper, which is published in 2021, it's very important that in India, sometimes in the first 5 years of the diabetes, the people take it very lightly, that they have just diagnosed with diabetes. Some of them, they say that it is still in a borderline condition, but their HbA1c is more than 8 or 8.5. And sometimes they come to diabetologist or a physician who is practicing diabetes with a complication within 3 years or 5 years of diagnosis, or maybe some of the patients even at the time of diagnosis, because the diagnosis itself was delayed. So the early and aggressive management of diabetes along with obesity management is very, very important for a primary care physicians or all those doctors who are treating diabetes. The presence of microvascular disease, actually it predicts the macrovascular disease. So suppose somebody comes with the albuminuria or somebody comes with a retinopathy, that itself is also it predicting that they are going to have the macrovascular disease in a near future. And this paper had also talked about a long back that presence of microvascular disease does not mean that we are only dealing with the diabetes microvascular complication. It means it's a other complication also going to start, and they are going to have the macrovascular complication in very near future. The burden of complication in a newly diagnosed patients are very, very high, particularly in lower middle income countries. And across all the patients, if you just take the cross section, you will find a lot of patients not only have retinopathy or a neuropathy or microalbuminuria, but we have a lot of patients with the peripheral artery disease or ischemic heart disease or stroke, or even with some of the patients with diabetic foot, which is in combination of micro and macrovascular complication. We also have one more problems, that we are now getting diabetes in younger and younger population. Before, sometimes we were talking that we are getting the diabetes in our patient, which is already 15 years before the Caucasians they get, and we get diabetes in 40s. But now we started getting even in 30s, 20s, and now even the young type 2 diabetes that had also become a problem for our country, and particularly from the Asian countries and from some of the even from US also, it had become a very major challenge because of they are getting way too much. So we should focus not only on complication, but preventing complication. And that's the main goal. If you see the ADA guideline on the left side, there is a holistic person-centered approach to type 2 diabetes management, where they are talking that complications are the principal cause of morbidity and mortality. Complications are already or often present already at the time of treating or when you are seeing the patients, even some of the patients with the diagnosis, there is always a coexistence of micro and macrovascular risk, and certain subgroups are more susceptible to some of the complication, like patient with SERD have more with NAFL, patient with SID, they have more with microvascular complication, patient with obesity-induced diabetes, they may all have risk of cardiovascular disease too. So when we should start preventing complication, and here you should remember the legacy effect. Earlier, and tighter glycemic control is going to give the lifelong legacy effect, and that we have to understand, that we have known from the UK PDS data also, and this data has been even also seen in the advance, which was in 2008, and even legacy data, one more paper which is published after 10 years follow with the real world cohort of patients with newly diagnosed. those who have early and tighter glycemic control less than 6.5, even with 1 year of diagnosis, those patients in first year of diagnosis, if they keep their HbA1c of less than 6.5, found to have less complication throughout the life, while in compared to those patients who have more than 6.5, found to have more micro and macrovascular complications throughout the life. And this 10-year follow-up data, which is published and showing that a legacy effect remains for the people who are not only diagnosed early, tighter glycemic control, and given a long-term less complication and using the molecules which is going to give them a long-term tight glycemic control, and think of always obesity when you are managing. The early use of SGLT2 inhibitor attenuates the association between poor metabolic control and CVVAD. So even those patients who have not very good control, but still adding them with the SGLT2 inhibitor will give them a benefit of this legacy effect as far as CV events are concerned. So the legacy effects when blood pressure and lipid control will also help them for getting less cardiovascular complications. So the blood pressure A, B, C, that is what the A1C, after that the blood pressure tight control, and even the lipid control, which will also help for these people to have less all-cause mortality as well as cardiovascular mortality. And these two trial of advance, which is with that blood pressure lowering, how the benefits are there, and in VOSCOP in the lipid lowering, how it is going to give the benefits for the patient who are better controlled with blood pressure and the lipids. How we should prevent the complication. Now, this is a map out to strategy to manage diabetes effectively with goal to reduce the risk of complication. It is not only, as I told you, the lifestyle changes, structure education, early intensive glucose lowering, multifactorial risk factor control, and early use of disease modifying agents. I mean, you have to treat diabetic patients with a holistic approach where you have to think of education and lifestyle modification along with a early intensive glucose control with multifactorial risk factors control also. Here too, we talk about the Verify study, which is talking about the early combination therapy, which was published in 2020. We talk about the evidence for early combination therapy in the early and young onset diabetes. In these patients, when we are followed, you can see that these patients were benefited proportionally more than patients who were showing better glycemic control, durability, and delayed treatment escalation. So these patients remained with a good control of diabetes with a combination of DPP-4 inhibitor with metformin. Management of diabetes is becoming increasingly complex. Yes, because one side we want to treat the obesity, one part of it we want to control all the cardiovascular risk factor, and the third is those who have established cardiovascular disease or patient with heart failure or patient with CKD. We have to modify and giving them a therapy which will help them to reduce the complication or modify the pathway of these complications for these patients. So the focus is always for the preventing complication in newly diagnosed patients, whether it's a diabetic kidney disease, retinopathy, peripheral neuropathy, peripheral vascular disease, stroke, or coronary artery disease, or heart failure. Now, very important, as we know that we were knowing diabetes, it's always a progressive disease. 2017-18, the paper of Professor Sproul, that he told that no, it's not, it can be remission. And his first hypothesis was in 2007. And then he talked about the achieving remission is possible for the patients who are having diabetes. And his hypothesis was published in 2008. It is the excess liver fat which is responsible for the beta cell dysfunction. And then he had talked in counterpoint study in 2011, the testing his twin cycle hypothesis, and that was published in 2011, and then direct remission, which he has talked for 24 months. The weight reduction was significant. We had gone for this study multiple times. In the 2 years, they had shown 64% chances of remission. But what he had shown here, the 5 years data, the 5-year follow-up data of those patients from the primary care center, the average weight reduction still remained 6.1 kg. That's very important. Even the remission was there for 13% of the patients. So it means it's like that those patients who are having sustained weight loss and continued to remain in weight loss, they all kept and they were in remission. It's a long-term remission for type 2 diabetic patient. For the weight loss was there for the patients who are having average weight loss of 6.1 kg. Those who minimized weight regain, they stayed in remission, and that baseline was 8.9. So the 13% weight patient, those who are having remission, actually their weight reduction was around 8.9 kg. The effect of remission was not only on the people who have diabetes, but for the complication also. This is the data from the paper of Look Ahead, and that they had shown the people with CKD and CVD, the number of years with the remission, they found to have less complication of CKD and CVD too. The remission of type 2 diabetes should be a priority for many, if not for everyone, at least for the people who are newly diagnosed. Those are having obesity is the primary, because it depends on the weight loss. It can be long term, and it brings major health benefits to our people with diabetes and with obesity. It is still about glucose until proven otherwise. So newly diagnosed type 2 what should be the focus of management. The David Nathan had showed this very clearly. Professors, a persons with a who had talked that it's still about glucose unless it is proven otherwise. And what he talked about, the association of glycemia with macro and microvascular complication with UKPDS, he had shown the data to show that still the sugar uncontrol is the major reason for them to develop all micro and macrovascular complication. Definitely, intensive blood glucose control will reduce the complication of micro complication significantly, but it also helps for the macrovascular complication. So the relationship between glycemia and microvascular complication is well established with the data of UKPDS and DCCT, and the major findings had shown the people who have better control of diabetes will definitely have less microvascular complication, whether it's a retinopathy or nephropathy, which also helps in for neuropathy and other major complication. The metabolic goals for all these patients are always the A1C, lesser the A1C, less than 6.5 or 7 will always help for these patients to have less and less complication with these patients, and every single digit reduction in A1C also helps in the patients with micro and macrovascular complications. The ADA algorithm is very clear in 2024 that how we will treat the diabetic patients. Always look for the established complication, look for the risk, the other risk factors for the people with micro and macrovascular complication they can have, and intensive glycemic control should be our priority, along with obesity management and screening complication. To conclude my presentation, type 1 and type 2 diabetes remains a glucocentric disease. But yes, you should always think of complication preventing approach should be there. Diagnosis is predicted on an elevated glucose level. That's the only way how you can diagnose. Hyperglycemia is the only universal link between all forms of diabetes and morbidity. The long-term complications of diabetes are intimately associated with hyperglycemia. Experimental evidence, randomized clinical trials have proved the causal relationship between hyperglycemia and diabetes-specific complications. On the basis of these factors, glucose control remains at the center of diabetes care. With this, I thank USV, I thank all my colleagues who had given me an opportunity that I'm talking all the way from Orlando to all of you and directly in touch with you. Thank you very much.
Thank you, Dr. Bansi Sabu, for your excellent deliberation and summing up what has happened at the ADA over the last 2 days. And the updates will certainly benefit the people who have joined us today. And one thing is sure that the management of the glucose, as rightly pointed out by you, is glucose management will always remain in the center. But one shift which we can see easily happening is nowadays the obesity is also one of the major challenge which is now being addressed along with the management of diabetes and the organ protection is something which is again at the focus while managing the glucose levels. So thank you very much for your deliberation. And now I would like to invite our second speaker, Dr. B.M. Makkad. Dr. B.M. Makkad, as you all know, he is the immediate past president of the RSSDI, and he is also the honorary secretary of the IRO, and also he is the director of the Dr. Makkad's Diabetes and Obesity Center, New Delhi. He is member of various organizations and has been in leadership positions in various capacities with many organizations. He is a recipient of multiple awards and orations, and he is also a renowned figure in the field of diabetes. Has published many books and published papers in many national as well as international journals. And as we all know, at the center of any conference, we are always interested in knowing that what are the new trials which are being presented, and what new information has come which is going to impact the way we care for our patients. So I would request Dr. B.M. Makkad to give insights into the latest trials which are being discussed at ADA, and what is his opinion about them. And over to you, Dr. Pankaj.
Thank you, Dr. Amit, and good evening to everyone in India. At the outset, I would like to thank USV for this great opportunity and also thank Amit for a very kind introduction. In this presentation, I'm going to touch upon two trials that have been presented here. One is the trial with inhaled insulin, which is presented here, and second is the trial, a select trial, which is the CV outcome study with semaglutide. Are you able to see my presentation?
Yes, we can see, sir.
Okay. It's not moving. It's not moving. Hmm?
बैकएंड से कर देंगे मूवी
Move.
उनको ना नेक्स्ट
So, can I have the control with me to move the slides? Ashili?
से टेक
Tech team, can you please help sir do that?
Yeah, sir, I'm sending you request.
उनको ना
हाँ,
नेक्स्ट
हाँ, Then
Okay. So first is the inhaled trial, inhaled 3 trial, which is the trial with inhaled insulin. Inhaled insulin is basically technosphere insulin, or TI as it is termed. It is a powder form of insulin, which is created by absorbing insulin on the FDKP or diketopiperazine molecules. And it is a powder in powder form at pH of less than 6. Once it is inhaled in the lungs where the physiological pH is more than 6, it's around 7.4, so it gets immediately dissolved. The inhaled particles dissolve very rapidly and rapidly absorbed into the blood. So that is why you can see that, this has a very sharp rise in the blood concentration and has a equally sharp decline in the effect. And there is no risk of postprandial hyperglycemia before the next meal. So its action profile is much more faster as compared to the rapid-acting insulin. This is available as cartridges, and this comes with an inhaler, which is actuated by breathing. So this is some basics. So inhaled trial, basically it's a randomized multi-center trial comparing insulin, technosphere insulin, or inhaled insulin along with the degludec, compared with the usual care, which involved patients on the automated insulin delivery or sensor-augmented pump or multi-dose infusion of insulin. And they were all using personal CGMs. There was 17-week period was the randomized control trial, and after that there was 13-week extension where both the groups used degludec and TI. These are the centers, and these are the key inclusion and exclusion criteria. The exclusion criteria were anybody using any other drug than insulin, any history of asthma, smoking, or lung cancer. Pregnancy was one of the contraindications. Inclusion criteria were adults with type 1 diabetes with A1C less than 11% on consistently on the same insulin delivery method for last 3 months and having a total dose of insulin requirement between 20 and 100 units, and they were using CGM on regular basis. So degludec dosing was, started on the basis of the total dose calculated on the time of initiation, and the conversion of the inhaled insulin to random rapid-acting insulin was in the ratio of 2 units of inhaled insulin for 1 unit of rapid-acting insulin. During first 4 weeks, the meal dose titrated was based on the 1 hour postprandial continuous glucose monitoring. And if the glucose was consistently more than 140, dose was increased by 4 units of Afrezza or TI. And if it was more than 200 milligrams per deciliter, the dose was increased by 8 units. For every, correction dose was again given as 4 units if the increase, the sugar levels are between 140 to 180, 180 to 140 to 200, 8 units if they were more than 200, and 4 units at bedtime. So study outcomes looked at the efficacy and safety of inhaled insulin or TI. If you look at the baseline characteristics, there were slightly more women in the study as compared to men. And if you look at the overall distribution of people on different types of insulin, 48% were taking automated insulin delivery method, 44% were on multi-dose insulin infusion. That was the largest component. After screening, the randomization happened 1-to-1, total of 123 patients, 62 randomized to TI, 61 to usual care, and 17-week was the first thing. So first step was the comparison of inhaled insulin versus rapid-acting in analog in users on automated insulin delivery or multiple dose insulin infusion in standardized in clinic meals challenge. So in clinic, they were administered a standardized meal consisting of boost, which had 240 calories, 37 carbs, and TI at the start of meal was given, or the rapid-acting insulin was given 5 to 15 minutes prior to meal. AID was continued, and the blood glucose measurement was done 15 to 30 minutes throughout 2-hour period, and the CGM was continued, which was blinded. So one group received TI, other group received the rapid-acting insulin. In comparison between 2 groups was done, and it showed that TI gave a much better overall reduction in the postprandial glucose post-meal challenge as compared to the rapid-acting insulin, whether these people were on pump or on the multi-dose infusion. And if you look at the glucose excursions in people who were on MDI versus non-automated pump, then the reduction was significant. Those on the automated insulin delivery, again, there was reduction in the meal post-challenge glucose levels, and the glucose excursions over 4 hours were much better with TI or Technosphere insulin as compared to the basal levels. And the meal challenge with TI at baseline and versus 17 weeks is seen in this slide. So you can see again improvement, at 7 weeks, which is consistent, which is persistent as compared to the time of randomization. And if you look at the overall glucose excursion profile over 4 hours, it is much better with the TI as compared to the baseline. So 17-week meal challenge in the RA group, TI dose given based on the RA meal. This was a meal challenge at home. So TI dose was given based on the typical RA meal dose given at home. And the analysis was done between the RA at baseline versus T1 at 17 weeks, TI at 17 weeks. So if you see the comparisons between TI versus RAA, TI performed much better in terms of regulation, the control of glycemia. If you look at for 60 minutes or 120 minutes post-meal challenge. And if you look at the glucose excursion by insulin delivery method again, whether it was the MDI or the sensor augmented pump or the automated insulin delivery, TI performed better. And if you look at the glucose excursion over 4 hours period, again, it performed better as compared to the baseline. That was the randomization time and compared with the 17 weeks, which was the end of the study period. Now, if you look at the combined both meal challenges, TI performed better as compared to the RAA. And if you look at the 17 weeks optimized dose of TI, again, it performed much better than the RAA as compared to the baseline level. So in summary, The post-meal hyperglycemia was reduced with TI, which is technosphere insulin or Freeza, with as compared to the subcutaneous rapid-acting insulin given. And reduction in the post-meal hyperglycemia with TI was greater for MDI users than the AID users. Greater reduction in post-meal hyperglycemia was observed with higher TI dose at 17 weeks compared to the baseline dose, and post-meal hyperglycemia was infrequent with TI as compared to the rapid-acting analog. Then the second part of study was the efficacy, safety, and quality of life outcomes. And again, this is the randomization which happened at the baseline. So if you look at the A1C, there was no difference in the A1C at 17 weeks as compared to baseline, whether it was per protocol analysis or as the primary endpoint. And if you look at the A1C as secondary endpoint, TI insulin versus the usual care, there was significant improvement in the people achieving less than 7% at 17 weeks. And HbA1c improved more than 0.5%, again, significant number of people on TI at 17 weeks. But the interesting thing was A1C also worsened in significantly higher numbers on people who were using TI at 17 weeks. And if you look at the distribution of people, then you can see there is a huge, variation in the bar diagrams. And this showed that some of the people were actually missing dose in the TI arm. And that was the reason why you could see, the number of people having worsening of the A1C also. Now, if you look at the percent time spent in less than 70 milligrams per deciliter levels of glucose levels, it was similar both in the both arms in TI at baseline versus TI at 17 weeks, and percent time spent in less than 54 milligram per deciliter again was slightly lower in TI arm as at 17 weeks as compared to baseline. Now, if you look at the time in range, this was overall, there was no difference between the TI at baseline versus 17 weeks. But the time, if you look at night time, this was again more or less similar, but there was slight decrease in the time in range during night in people who were on TI at 17 weeks as compared to baseline. Again, if you look at the time in range of 70 to 180, there was increase in people who were achieving TIR of more than 70%. There were increase in number of people who achieved more than 10% improvement in TIR. But again, TIR worsened in higher number in the TI group because of the missed doses. Other outcomes that were looked were the change in weight, which was not different. Safety outcomes, there was no issues. There was mild cough was the most common side effect, and the serious adverse events, if you look at terms of severe hyperglycemia, it was hypoglycemia. It was, numerically, there were very low episodes, but it was still lower in TI. The cough was the mild cough was the most common side effect, but it was not an issue, and, there were hardly any major problems. So most important learnings from INHALE-3 are that using TI may be good for patients who are engaged in their self-diabetes management and want to reduce hyperglycemia even further. Using TI may be good for patients who want an alternative to pump, and to maximize benefit of TI, you need a repeat inhalation at 1 to 3 hours if the post-meal glucose is more than 140. It is important to understand that how patient is to be educated to get the best results with TI. A second trial that I am presenting here is the semaglutide in CV outcome trial, or the SELECT trial. This has already been published in New England Journal of Medicine. So this is basically a CV prevention or secondary cardiovascular prevention trial, because individuals with overweight or obesity have high cardiovascular risk, and they are candidates for secondary prevention of heart disease. So this study basically included, this was a multi-center randomized multinational study. included overweight or obese individuals more than 27 BMI, age more than 45, and established atherosclerotic cardiovascular disease without prior history of any diabetes or documented diabetes. And there were more than 17,000 patients randomized to semaglutide versus placebo. The dose escalation of semaglutide was done over 16 weeks period, and then it was maintained. The average exposure to semaglutide was 34 weeks, and the average follow-up was what? 34 months, and average follow-up was about 40 months. Key inclusion criteria were the prior established ASCVD, men, women over 45 years of age and BMI more than 27. The key exclusion criteria was type 1 diabetes and NYHA class 4 heart failure. There were primary endpoint was 3-point MACE, and the confirmatory secondary endpoint was the CV death composite of heart failure endpoint consisting of heart failure hospitalization, urgent heart failure visit or CV death, and all-cause death. There were other CV endpoints and other metabolic parameters which were also explored. This is the trial, participants' characteristics: 27% women, majority men, average age 61.6 years, 84% white population, 67% having MI, 18% having stroke, 4.4% having PAD, and more than 8% having 2 or more, established conditions. So mean BMI was 33.3, eGFR was 2.5, chronic heart failure was present in 24.3% of the population, and 66.4% had prediabetes. These were the other conditions which are present in people with the obesity. They were, after screening of 21,000 plus patients, 17,600 were randomized to receive semaglutide versus placebo, and 97% of the patients in both the arms completed trial. The results showed remarkable significant reduction in 3-point MACE, which was 20%, and had statistical superiority over placebo. So this trial is basically comparing semaglutide added to standard of care in people with obesity or overweight as compared to placebo for management of obesity. So as compared to placebo, there was 20% reduction in the overall 3-point MACE, which was statistically superior. There was another 15% reduction in the death from CV causes, which was not statistically significant, but there was trend towards benefit. There was statistical superiority confirmed for the secondary endpoint, which was the composite of heart failure events, reduction by 18%, and reduction in all-cause death by 19%. If you look at the overall benefit on various components, you'll see there was benefit for almost all components of cardiovascular disease. There was 10% weight loss, which happened in the first year itself and was sustained over the 4 years follow-up. And this was again, significant. Then if you look at the changes in the waistline, again, there was significant reduction in waist circumference of about 8 centimeters, which was sustained over the trial period. There was 0.31% reduction in A1C, and there was 61% reduction in the, there was significant reduction in the people who were, having prediabetes. So if you look at the baseline, this is the proportion of participants had baseline A1C of less than 5.7% was 33.2%, and at the end of 4 weeks, this number almost doubled. While in the placebo group, this number came down by almost another 50%. There was 4 by 1 millimeter reduction in blood pressure. There was significant reduction in the hs-CRP levels. There was overall improvement in the lipid profile. And if you look at the side effects, there was, again, the same similar GI upset was the only issue that was there. If you look at the significant concerns that are there are the acute pancreatitis was not different from the placebo group. No significant difference in the malignant neoplasm or gallbladder-related diseases in people who were treated with semaglutide. So in people with pre-existing cardiovascular disease and overweight or obesity, but without diabetes, weekly subcutaneous dose of 2.4 milligrams semaglutide was superior to placebo in reducing the incidence of death from CVD, non-fatal MI, non-fatal stroke over a mean period of 40 months. So semaglutide showed a significant reduction in MACE and overall all-cause mortality, showed a significant consistent benefit across the measured CV endpoints, improved the multiple modifiable risk factors, which included weight, waist circumference, blood pressure, lipids, and hsCRP. These findings are very consistent with the previous findings, which were observed with the semaglutide 2.4 milligram during STEP studies. And this is the first, CV outcome trial showing significant reduction in CV events in people with obesity managed with, semaglutide for management of obesity without diabetes. As I mentioned, this has already been published, and thank you for that. Thank you for your attention.
Thank you, Dr. Makkar sir, for presenting the major trials here, which have been discussed at the ADA 2024. And the major trial, as you have already mentioned, the INHALE 3 and the SELECT trials. So INHALE 3 with the inhaled insulin and SELECT with the semaglutide. And they have shown very, very promising results as far as management of glucose is concerned with inhaled insulin. And also the SELECT trial is promising for a reduction, for a significant reduction, even with those people who have an HbA1c of less than 5.7%. So with this, I thank you so much for your presentation. And now I would like to invite our next speaker. And next speaker is Dr. Rakesh Sahai. Dr. Rakesh Sahai, as you all know, is currently the president of the RSSDI, and he's immediate past president of the Endocrine Society of India also. And he is editor, author, researcher of multiple textbooks, and he has published several papers in very credible journals. And he has awards like Fellowship of National Academy of Medical Sciences to his credit. And he has been awarded with the Best Teachers in Medicine award by the government of Telangana in 2018 also. More than 180 publications. And it is an honor for RSSDI that for the first time ADA has invited an RSSDI president to deliver a talk at ADA scientific session. So not only just today he will be speaking at the ADA, and he will speak on cardiovascular risk management, disease management in people with diabetes in India. So congratulations, Dr. Rakesh Sahai, sir. And
Thank you, Amit. And I am handing over to Dr. Rakesh Sahai. Thank you.
Yes, sir. Thank you. Thank you, Makkar sir. Thank you. So now I will request Dr. Rakesh Sahai to proceed with his presentation.
So good evening to all of you. We are here in the morning at Orlando at the ADA. So it's my pleasure to present to all of you some of the snippets regarding therapy areas of diabetes. We may not be covering everything that has been discussed, but some snippets will cover, and we have more to come up in the next 2 days, today and tomorrow. So I'm sure we'll be catching up with a lot of more information in the next 2 days also. But as of now, what was discussed in the last 2 days, I'll just quickly summarize some of those issues, and I'll be giving a brief overview of the discussions that happened, and then we can any questions I can take it up. So let me have the presentation, Dr. Ashley. Yeah. So I think one of the most interesting debates which happened was, regarding sulfonylureas in type 2 diabetes management. Should they stay or should they go? This is something which is of great relevance to our country also, because, we know that even though we have so many new agents, we still have a lot of importance for the sulfonylureas. They remain as the most widely used therapy or widely used molecules for the management of diabetes. And therefore, we always have this a very interesting debate happened, and I will just take you through what was discussed during this debate. Next slide. So I think one of the important messages that came out of the debate, although I'm giving you the conclusion of the debate in the initial phase itself, is that sulfonylureas remain important, useful agents in the management of diabetes. Why do they remain so? Let's quickly look at what both the proponent and the opponent spoke about during the debate. Next one. Yeah. So the proponent actually, who was speaking in favor of sulfonylureas, actually brought out this very important construct where he said that when you look at using sulfonylureas, what are the scenarios where you start using sulfonylureas? I mean, think of using sulfonylureas where lifestyle modification at onset of diabetes itself, where lifestyle modifications have not really worked. Whether you would use sulfonylurea, there's an option of using sulfonylurea. Today we have the option of using various other drugs, and then you have as a second line medication, because most of the time we see that metformin still remains, whatever the debate is. Metformin is an important molecule which is used in majority of the patients as a first line therapy. So after metformin, what should be the next therapy? Next therapy to be decided is often a debate between whether it should be sulfonylureas, whether it should be GLP-1 R8, whether it should be DPP-4, whether it's SGLT2 inhibitors or basal insulin. Some years back, it was sulfonylureas were rather a natural choice after metformin. But today, with the availability of all these different agents and the evidence that we have about all the other molecules, we have a debate. We have to think over it. We have to think about what should be the second line of therapy. Next slide. So, I mean, if you look back at the data from the UKPDS study, we clearly see that sulfonylureas have a very good efficacy in terms of bringing down the HbA1c. There was a clear 1% reduction in HbA1c with the use of either metformin or sulfonylureas. There was a group which was only on sulfonylureas. There was a group which was using metformin alone, and then a group which was with combination of both metformin and sulfonylurea. And clearly over the period of follow-up, 10 years of follow-up, clearly it was seen that sulfonylureas were effective, brought down the HbA1c by on the average by 1% in the entire group. And next slide. And however, the major concern that was remained was that sulfonylureas cause hypoglycemia and weight gain. So if you look at hypoglycemia itself, we have, so the decision number 2, which we're saying, you have the choice between different agents, because when you look at these different agents, you look at two important aspects. One is the efficacy aspect. Second is the side effects aspect, the adverse events. So the adverse events are mainly hypoglycemia and weight gain. So if you look at hypoglycemia itself, if you see the effect of different, I mean, the risk of hypoglycemia with different agents, as you can see in the GREAT study, which was a very elegantly designed study, which was published about 2 years back, which showed that, which compared the addition of all these 4 different molecules as second line molecule after failure of metformin alone. And there in that trial, what we see was that the risk of hypoglycemia with sulfonylureas was clearly higher than the rest of the group. But again, if you see, it probably is not as significant as you would otherwise be worried about sulfonylurea causing a significant hypoglycemia. Next slide. And then if you look at the risk of microvascular complications, again, you see that there was no material difference in terms of the microvascular complications between any of the 4 molecules that you use, whether you use SUs, that is glimepiride, or whether you used sitagliptin, whether you use liraglutide, or whether you use any of these molecules did not bring about a significant difference in terms of the bringing down the microvascular complication. All of them did it to the same extent. Next slide. But when you look at the cardiovascular disease itself, you find that there was a slight difference, small difference in CVD rates, and the rates being more in favor, lower with the use of liraglutide as compared to the other molecules. As you can see, this was also borne out by the cardiovascular outcome trial of liraglutide lead study, which has clearly shown the cardiovascular benefit of liraglutide, and that comes out again in this study, in the GREAT study, where again you see that the if you compare these molecules, you see that there was a little difference, while there was no difference in terms of microvascular complications because all of them brought down the HbA1c, but liraglutide with its additional benefits in terms of the weight reduction had the benefit in terms of reducing the cardiovascular events. Next slide. And if you look at the all-cause mortality, there was no significant difference in the mortality with either of these agents. So again, all these points speaking in favor of using any of the molecules in terms of when you're looking at the all-cause mortality, but when looking at cardiovascular benefits, you have an edge with the use of liraglutide. And when you look at hypoglycemia risk, although there's not much difference between the other three agents, glimepiride was associated with a slightly higher risk of hypoglycemia. So you have to see whether this offsets against the benefits that we see with the use of glimepiride. Next slide. So these are the considerations that we have, whether we look at any of these molecules when you're looking at addition of one of these molecules to the first-line therapy, which may be metformin in majority of our patients. Unless now we are speaking of using the SGLT2 inhibitors or the GLP-1 analogs as first-line therapy, when we have a clear-cut indication, that is whether when we have renal disease or cardiovascular disease. But we are speaking of a scenario where these two compelling indications may not be existing in that particular patient. Next slide. Next, good. Yeah. So I think So I think this again shows that this slide speaks about what is the impact of SUs in terms of the diabetes complications with the long in older adults with long duration of diabetes. What are the risks? What are the various factors that can contribute towards the risk? And this is clearly borne out that when the duration of diabetes is 10 or more, there are factors that we need to look at, the acute hypoglycemic events, hyperglycemic events, and even renal disease and various complications we need to look at. Next slide. So having looked at those aspects, now let us see that there are certain situations where sulfonylureas are the drugs of choice, whereas in all other situations we are looking at looking at various factors to decide whether we should use sulfonylurea or not use sulfonylurea, whether we should choose these over other agents, or that is the scenario earlier. But if you come to certain another scenario where we are saying that sulfonylureas are the natural choice in this group of patients, that is patients with the MOD3, where sulfonylureas have been found to have a particularly beneficial effect, and even in patients who have been on insulin for several years can also be transitioned to sulfonylureas, because the defect there is in terms of the insulin secretion because of a single gene defect, which is causing defect in insulin secretion, which is affecting the SU receptor, and by addition of SU, you're overcoming that defect, and sulfonylurea is able to stimulate the insulin secretion, because the effect of the insulin secretion is improved by the use of sulfonylureas, which cause the closure of the potassium sensitive ATP channel and cause release of insulin. So this is a scenario where sulfonylurea are required for management of these scenarios. Next. Then there are other issues that need to be considered. So having looked at these, in the other scenarios, you're looking at one is we've looked at the efficacy, which we said that sulfonylureas have a very good efficacy. Then we looked at the other issue of hypoglycemia. Then we looked at the issue about compelling indications for use of sulfonylurea, whether they reduce the complications. And then finally, when looking at the price, because ultimately the price is what decides what molecule is used by patients. And here you see that sulfonylureas have a clear edge because the cost of therapy comes down significantly. Particularly in our country, it may not be so much of a difference, but in the West, there is a significant difference in cost between SUs and between using any of the newer therapies. Next slide. And so this is a comparison again given in looking at the international figures of what costs would be incurred when you're using SUs as compared to using other forms of therapies. And clearly we see that SUs have a clear advantage in terms of the cost. Next. And therefore, when you look at a construct here where you're looking at a cost effectiveness analysis, you clearly see that sulfonylureas become a preferred agent because they are influencing the outcome favorably, while they are at very low cost, while although there may be some issues related to it, but obviously you see that the cost benefit analysis clearly is in favor of SUs. Next. So again, the cost effective innovation here clearly shows that use of sulfonylurea is the construct here again gives us the same message. Next slide. Next. Yeah. So I think when you translate that into cost quality associated life years, you find that this certainly makes a huge difference because the cost is down. You're having a benefit in terms of the complications, and certainly the quality associated life years are significantly better with the use of SUs and as compared to most of the other therapies which have a very significantly increased high cost is attached with them. Next. Yeah, again, this also shows us the total spending with different medications. Next slide. So what we need to look at is whether we are looking at an individual in terms of the benefits we are providing, or whether we're looking at a population health issue. And when you're looking at a population health benefit, certainly SUs stand out. When you look at an individual health issue, then what we see is that to treat one person with GLP-1 we could treat 177 people with sulfonylurea. So this is on a population level, whereas in individual, where it is indicated there is a need for the use of molecules like GLP-1 or SGLT2 inhibitors in preference to sulfonylureas, even though the cost may be higher. That is to justify the cost. If there is a clear benefit produced in terms of the complications, then I think the cost is justified. So next slide. So in summary, the proponent highlighted the fact that sulfonylureas have been used for a long period of time and as a second line therapy. In first line therapy, in some scenarios, particularly in Indian scenarios, we see that the first line therapy also sulfonylureas have an important role to play. Then he highlighted about the need for the use of sulfonylurea in certain specific indications, and also highlighted the cost benefit in terms of various ways in which he has analyzed the cost benefit and shows us that sulfonylureas clearly have a cost benefit in terms of when you're looking at a population wide analysis. Next slide. So interestingly, the opponent who spoke to us about do we need to stop using SUs for type 2 diabetes highlighted the facts. Next slide. Highlighted the three major issues, namely the good aspects about SUs, the bad aspects, and the ugly aspects. So if you look at the bad and ugly aspects, the good aspects, we are very clearly aware about the lowering of the HbA1c, which is significantly very good. And then the reduction in complications, which was shown by UKPDS, and the fact that they are very economical medications, where, as was shown by the proponent of the debate, the opponent brought out the importance of the factors that we have to be careful about while using SUs, namely the hypoglycemia, which is certainly a significant issue, and she has highlighted that it is probably more than the insulin also, the weight gain that occurs with the use of SUs, and the reduced quality of life and the lack of non-glycemic benefit, the absence of the non-glycemic benefits. We see the glycemic benefits, but the non-glycemic benefits are seen more with the SGLT2 inhibitors than the GLP-1 analogs. Next slide. So she also highlighted the fact that all the SUs are not the same, and this is something which again we have been reiterating from many years, that when you look at glyburide or glymentamide, that is different from the new generation molecules like glimepiride or glyclazide, which have more specificity in their action, and they are cardio neutral, you can say. They have no adverse cardiovascular effects, and they have a very low risk of hypoglycemia because they have do not have these active metabolites. Next slide. So she has actually highlighted the risks of hypoglycemia and how they are different in different individuals with diabetes, because no two individuals with diabetes are the same. There are individuals who have a higher propensity to have hypoglycemia, by others who have lower risk of having hypoglycemia. What are the side effects were also, and the other comorbidities that may be influencing the risk for hypoglycemia. Next slide. So the GRADE study, again, she brought in the aspects of GRADE study and showed that the risk of hypoglycemia was higher with the use of glimepiride as compared to liraglutide or sitagliptin, and clearly showed that it was statistically significant. She also highlighted the fact that it was more than the more than the risk of hypoglycemia seen with even with the use of glargine. Next slide. So in a meta-analysis of the use of various sulfonylureas, we see that probably glibenclamide, as we just spoke about, has the highest risk of having hypoglycemia. When you compare a meta-analysis of various RCTs, you can see that clearly this fact is brought out. Next slide. So again, the other aspect that was highlighted was about the weight gain. So if you look at the weight gain, it was similar to what was seen with insulin, and but certainly higher than what is seen with liraglutide, which has the lowest weight gain. Only 6% of patients on the liraglutide arm had gained some weight, while others had lost weight. Whereas with sitagliptin, about 9% of the patients gained weight. With glimepiride, 12% of the patients gained significant weight, which is more than 10% weight gain was seen in 12% of the patients, as compared to 6.1% seen with liraglutide. So again, if you see, the weight gain happens, as we know, when we use sulfonylureas. The weight gain is mostly in the first 1 or 2 years, and it may not be very significant, as you can see in this 4-year study. Only more than 10% weight gain was seen only in 12% of patients with the use of glimepiride, and in the same study, 6.1% of patients with even using liraglutide had more than 10% weight gain. So clearly shows that weight gain is an issue not just because of SUs, but because of the better glycemic control that is achieved. And even with molecules like liraglutide, you can still see that about 6% of patients did gain weight. Next slide. What about the cardiovascular risk? Next slide. Next, please. Yeah, so if you look at the outcomes, again, in the previous speaker's presentation, also we brought out the fact that when you look at the cardiovascular risk, it is slightly lower with liraglutide, while the microvascular complications did not differ between the different molecules. So once again, when you're looking at a cardiovascular benefit from the molecule, then we are certainly choosing either liraglutide or SGLT2 inhibitor. Next slide. This study, the GRADE study, did not have SGLT2 inhibitors because they were not available at the time that the study was initiated. Now, we have data from the Carolina and the Carmelina study, which give us a lot of information. The Carmelina study showed with linagliptin, showed that linagliptin is safe as compared to placebo. And in the next study, that was Carolina study, this was a head-to-head comparison between linagliptin and glimepiride, and it showed that glimepiride was as safe as linagliptin in terms of the cardiovascular events or the major adverse cardiovascular events. So clearly showing that if you put these two together, then we clearly understand that that glimepiride is also cardiovascular safe, and this is one of the newer sulfonylureas which has been shown to have this cardiovascular safety. Next slide. Yeah, so what we see is that, but when you compare between the sulfonylureas, again, clearly this aspect is brought out very clearly that that the newer molecules like glycoside and glimepiride, which are the new generation sulfonylureas, you can say, are much more safer than the older generation sulfonylureas, and they have definitely a better safety profile as compared to the older molecules. Next slide. Next. Yeah. So when using a sulfonylurea, the caution was that we should choose a short-acting sulfonylurea. You should use glipizide to reduce hypoglycemia risk, but otherwise use glimepiride or glycoside when you're looking at the cardiovascular safety of these molecules, and use the lowest effective dose. Start with a smaller dose, uptitrated gradually, and also reduce the dose in situations where like CKD, in situations where people are at higher risk of hypoglycemia, these molecules, these dose of these molecules should be reduced, and also probably avoid them in people who are obese. Next slide. So clearly, what we said is that if they stay, the opponent of the debate had to concluded the debate by saying that if they stay, they do cause some trouble, but if they don't stay, they cause double the trouble, because they are other medications are not as effective as sulfonylureas, because we know that the whether we look at this DPP-4 inhibitors or the SGLT2 inhibitors, their effectiveness in terms of glycemic reduction or HbA1c reduction is lower than sulfonylureas. So you need more medications to get to the same glycemic target at a higher cost, and so therefore the trouble becomes more. It becomes double trouble if you do not want to use them. So that's why she says that she leaves it to us to decide what should we do, whether we should use it or drop them. So clearly, the message that came out from both the speakers was that sulfonylureas have certain benefits. They may have certain problems like hypoglycemia and weight gain, and these have to be balanced out by choosing it in the right scenario, choosing the appropriate sulfonylureas, choosing the right dose of sulfonylurea, because they are molecules which require to be titrated as per the requirement, and use it in appropriately, avoid using them in scenarios where there may be problems. So clearly, this debate showed us the importance of sulfonylureas. Next. Can I present it from here? Dr. Aushadi?
Yes, sir.
Can I present from here, or you can continue moving the slides? Yeah. So we now move on to the other aspect, that is on incretins and their effects beyond glycemic control, whether they have effects on the brain. So this was an interesting study. This was a free paper presented during the meeting, which was interesting, and I thought that we should have a look at this and see the benefits which are with semaglutide. The title itself tells us that the semaglutide reduces tumor burden in these diet-induced obese mice models, and those with biopsy confirmed MASH, that is metabolism associated steatohepatitis with advanced fibrosis and HCC. So clearly in these scenarios, what we see is that this molecule has been shown in this study, which I'll briefly go through the highlights of the study. I would request, please move to the next slide. This was presented on 21st, and basically this study was carried out to bring about the benefits, to look for any benefits with agents like semaglutide, and this compared semaglutide versus lanifibranor, which is a pan-PPAR agonist, because we have some data on PPAR agonists also having benefits on brain tumors. And we had some studies which showed rosiglitazone had this benefit in some of the tumors. And so this new pan-PPAR agonist was compared with semaglutide in these mice who had obesity and also had these and had hepatocellular carcinoma, because obesity is becoming an important cause for hepatocellular carcinoma. So NASH with hepatocellular carcinoma was a scenario where these molecules were used. Next. So this was biopsy confirmed MASH mouse models were used, and they were given this high fat diet, which led to the development of metabolism associated steatohepatitis, and some of these progressed to develop the HCC. And next slide. In these patients, this was biopsy confirmed HCC, MASH HCC mouse model, which was used in these studies. Next slide. Next, please. So what we find is that in this study, what was done was that they started after the liver biopsy and confirmation of this histology. Then they were stratified, randomized to receive receive semaglutide versus the other pan-PPAR agonists. Next slide. And what they see is that there were 4 groups, that is those who were receiving the clean vehicle, those who were receiving semaglutide, and the other PPAR gamma agonist, the pan-PPAR gamma agonist. So clearly we can see that as compared to those who were not treated, those who were treated with semaglutide had lower rates of had several benefits in terms of their weight, in terms of the persistent ALT and AST elevations, which were lower with the use of semaglutide as compared to those who were not treated. But the PPAR agonist also had the benefit in terms of having effect which is not equivalent to semaglutide, but better than the placebo treated mice. And there were also benefits in terms of their other markers of the histological markers and the biomarkers of tumor, which showed benefit with the use of semaglutide, and some of them also improved to some extent with the pan PPAR gamma agonist also. Next slide. So clear this again shows that there are benefits of semaglutide beyond glycemic lowering, and those benefits, apart from the cardiovascular benefits, you have benefits on metabolism associated steatotic liver disease also. And there are a lot of phase 3 trials which are already ongoing for the use of semaglutide in these indications, and we are awaiting the results of this. Maybe in a year or two we'll hear more about these trials, more about the results from these human studies, and I'm sure these are going to give us a lot of positive results. Now let me take you through this other aspect, is the effect of insulin resistance on incretin secretion. So this is a clear, we know clearly, next slide, that insulin resistance is a cause for diabetes. We always speak about insulin resistance. Next slide, please. We speak about insulin resistance being a cause for diabetes, being a cause for hyperinsulinemia. And so what we have, can you move to the next slide, please? Dr. Aushili, can you move to the next slide?
Yeah.
Yeah.
Yes, sir.
Yeah, so what we are saying is that we have a very good understanding about the incretin effect, because we have been using these molecules which have an influence on the incretin effect for several years, and we know that when the incretin effect is responsible for the additional insulin secretion which happens in addition to, I mean, when oral glucose is taken as compared to IV glucose infusion. For the same amount of rise in blood glucose, there is better insulin production happening with because of the oral intake, because of the incretin hormones, the GLP-1 and GIP being the major ones which are responsible for the enteroinsular axis, and these are shown to be lower in people with diabetes. So what we are trying to see is that whether the insulin resistance comes first, or whether the incretin effect, or whether the insulin resistance can have effect on the incretin secretion also, because we are saying that in this study what has been seen is that it is not just the people with diabetes who have a reduction in incretin levels, but also people with insulin resistance start having a reduction in the incretin levels, and that is something which has to be picked up, because we also have data from earlier studies which have shown that the incretin effect is maximum in people with without diabetes, normal individuals with normal glucose tolerance. As they develop insulin resistance, they have, or as they develop IGT, or impaired glucose tolerance, which is, or pre-diabetes, they have significant insulin resistance, and even in that phase, there is a decrease in the GLP-1 secretion. So that is clearly brought out in this. And another important aspect that is brought out is about the importance of the ratio of GIP by GLP. So let us move on to the next slide to see that. Yeah, so in type 2 diabetes, we know that incretin effect is severely reduced and contributes to about 20 to 35% of the insulin decreased insulin response to oral glucose, and the impairment of insulinotropic effect of GLP-1 and GIP are responsible for reduction in beta cell insulin secretion and are responsible for development of diabetes also, and that's the reason why we have a very good effect of these molecules. Next slide. So what we are saying is that there is a great variability in the incretin secretion even in normal individuals. That is, those who do not have diabetes, and probably those who do not have pre-diabetes also, because earlier studies we have spoken about pre-diabetes having that showing the decline in the incretin effects. But even amongst normal individuals, normal glucose tolerant individuals, based on their insulin resistance, there is a differential incretin effect as is seen brought out in this study. Next slide. So what we see is that the secretion of GIP, glucagon-like peptide 1, in patients with type 2 diabetes has been studied. A meta-analysis done on all the GIP-1 studies has shown, next slide, has shown that the GLP-1, if you look at the area under the curve during OGTT or mixed meal tolerance, we see that they are not much different. The GLP-1 secretion and the peak plasma GLP-1 during OGTT and MNT, as you can see, are reduced in people with type 2 diabetes. Next slide. Next slide. Yeah. So the presence or absence of type 2 diabetes does not meaningfully impair the GIP and GLP-1 secretion. Large population studies found a modest impairment of GLP-1 secretion in people with type 2 diabetes. And obesity and insulin resistance are often associated with decreased GLP-1 secretion. So next slide. Based on this, this study was done to investigate the possible defects in overall incretin secretion alongside the deterioration of glucose tolerance. So what they have looked at is the GIP-1 secretion, they have looked at GLP-1 secretion in the study, and they have compared the GIP by GLP-1 secretion ratio. Next slide. So this was a small study with about 41 subjects, of which who underwent oral glucose tolerance tests. They had a euglycemic lamp study and mixed meal test. All of them had these three tests done, and they were divided based on the response to the oral glucose tolerance. They were divided as NGT, which constituted 12 people in the group, and IGT in 12 people in the group, and diabetes was there in 17%, 17 individuals in this group. These were individuals who were detected diabetes after going through this test. Next slide. So if you look at the differences in terms of, obviously there are differences in terms of the fasting glucose and the which decides the difference between these three groups. And if you look at the fasting insulin, it did not differ between the three groups, but what differed was probably the even the C-peptide did not differ between the three groups, but what was different was the meal tolerance test. When it was done, they looked at the metrics of glucose disposal, and clearly that was different between the three groups. Next slide. And when you look at the meal tolerance test, as you can see that the three groups are differentiated by the differences in terms of the glucose, the insulin, and the glucose levels. Insulin and C-peptide levels did not differ between the group. They were all across this thing, the graph, but there was no clear difference between the three groups. Next slide. Next slide. So when we look at the GLP by the area under the curve for GLP-1 and GIP in these two groups, we see that the normal glucose tolerance as compared to the normal glucose tolerant individuals, those ones with IGT and diabetes had lowering of their GIP GLP-1 ratios. Next slide. And another interesting observation, the subjects with high area under the curve for insulin show higher non-glucose stimulated insulin secretion. So they are the ones who showed that they had the lowest incretin levels. So that clearly shows that with insulin resistance developing, there is a effect on the incretin secretion. Next slide. Next one. Yeah, so rather than altered secretion of incretin hormones per se, insulin resistance is the factor that leads to imbalance in the overall dynamics of incretin secretion after a meal, and the GIP-GLP-1 secretion ratio gets altered, and this may be an earlier marker of altered glucose metabolism, anticipating the appearance of type 2 diabetes. So this becomes an important marker in individuals who are, say, obese, have some insulin resistance. If they are having a alteration in this ratio, they are probably the ones who are going to develop diabetes as compared to those who do not have alterations in this ratio. So this is how this study can be interpreted as a potential way of differentiating individuals in the phase of who are normally glucose tolerant but have features of insulin resistance. How they can progress over the years can be distinguished with the use of this marker. Next slide. So with that, I'll conclude, and I thank you all for being here with us and listening to all the interesting results of various studies that we have shown from the ADA. Thank you.
Thank you so much, Dr. Rakesh Sai, sir, for your very explicit talk. Sir, would like to know, so what is your key takeaway from your talk, that your takeaway on sulfonylureas and the management of type 2 diabetes mellitus?
Yeah, so I think we had a very interesting debate. In that debate, what clearly came out was that sulfonylureas are very effective agents for glycemic control. So that is an important aspect that we have to keep in mind, and we have to keep in mind that these molecules do have a risk for causing hypoglycemia and weight gain. The weight gain may not be a major issue, but hypoglycemia can be a major issue in certain individuals who are having other comorbid conditions or those who have got renal dysfunction. There are certain clear-cut groups of individuals who have increased risk for hypoglycemia. In such individuals, we should see that we use lower doses of sulfonylureas, use them cautiously, and get the benefits in terms of getting them to the glycemic goals, while providing additional benefits if required in individuals who require additional non-glycemic benefits. Then the other agents can be added.
Okay. So coming to the non-glycemic benefits, so here in India, we are having so many FDCs upcoming with one or the other agents and different types of drugs we are combining. So are you seeing such type of papers or studies being presented over there offline also, apart from the live stream sessions?
Yeah. So I think maybe we'll be hearing more on these aspects, and then we'll update the newer studies that are coming up. But the available evidence clearly shows that there is a clear need for using sulfonylurea little later in therapy, as compared to 10 years back. We would use sulfonylurea as a natural second choice after metformin. But today we would rethink about it, use it a little lower down, maybe third or fourth line agent, as compared to using it immediately after metformin. And also for metformin itself, we are looking at scenarios where we may need other agents other than metformin as a first line therapy.
Sure. Any key takeaway from your end, sir?
Yeah, so I think the key takeaway was that SUs still remain important and we should develop the skill of using them effectively.
Indeed.
And keep our patients, give our patients the best benefits of all the molecules that are available. Because in our country, if we look back to our country, we see that at least the SGLT2 inhibitors and DPP4 inhibitors are off patent, and their the cost differentiation is not very great. So we should use all the agents effectively, see that we provide the best glycemic benefit to our patients with lowest risk of hypoglycemia, and not hesitate using molecules like SUs, which are useful when you need to get the patient to the glycemic target.
Correct. Thank you so much, sir. To summarize, first we have seen Dr. Bansi sir's talk. He spoke about the management of newly diagnosed type 2 diabetes that emphasized focused on the comprehensive management of type 2 diabetes patient. That includes management of obesity, glycemia, along with the overall metabolic health of the patients. Then Dr. Makkar sir talked about the inhaled trial and the select trial. And finally, Dr. Sai sir told us the importance, the relevance of the sulfonylureas in the management of type 2 diabetes mellitus that still remains prevalent and prevails in the management of T2DM even in the era of newer OADs. So on behalf of Team USV, it is my privilege to propose the vote of thanks. I would like to start by thanking our moderator, Dr. Gupta sir, for moderating the session, Dr. Bansi sir, Dr. Makkar sir, and Dr. R.K. Sahai sir for sharing your knowledge, time, and wisdom with us. Thank you so much, sir, for accepting our invitation. Thank you so much for your lucid talk. And just to update, sir, we had more than 2,500 logins for this session. So thank you so much, everybody, and have a good night. here in India, and have a great day at Orlando. Thank you so much.